So barriers for long-term heart failure rehab, probably the number one barrier is compliant. Patients are not compliant with everything they need to do because it's boring and they don't like to do it because they've never had to do it. Why do I have to do it now? Um, I want to drink my beer. I want to add extra salt. I like to eat soup. I don't want to weigh myself. All these things patients do not want to do. The other thing is patient education. They don't want to hear what you're saying. They don't want to keep track. Patients don't like change. Nobody likes change in their life. So these are barriers. If these two things could be instilled in everyone, everything would be so much better. Here are some most common nursing diagnoses for a patient with heart failure. So in clinical, these might be really important. Keep these in mind for clinical if you're doing those. So expected outcomes. What do we want the patient to accomplish? Well, we want the most optimal cardiac output for the patient, and we will do that by manipulating heart rate, amount of fluid, salt intake, how much using diuretics, using different medications, what the patient can and can't do. So we want the most minimal edema in the patient. We want the client's weight to stay where an optimal amount. We want their optimal function activity. We want them to keep on schedule with diet monitoring. We want them to pace their activities so they will not become tired. So all these things need to be worked. There's a lot of things a patient has to keep track of. So other treatments for heart failure, well, some things are out there that are basically buying time for the patient. For example, left ventricular assist device. This is a device that helps the perfusion, but you can't be on this permanently, so you're buying time for a transplant. Biventricular pacing, they have found if they put patients on pacing in both ventricles, sometimes that helps the cardiac output, or that does help the cardiac output. That's another thing to do. Continuous renal replacement therapy. These are patients that are very extreme. These are stage 4 patients on CCRT, and then patients getting a transplant. But like anything for a transplant, there's not enough organs to go around for all the patients that need them. Here is your, it's called a LVAD, left ventricular assist device. This is a device that basically the patient has a BAT control system, and they basically, the blood comes out from the ventricle and it goes back up into the aorta. So it's basically taking the blood out, it's speeding it up so you have increased ejection fraction. That's basically what's going on. So you can have acute heart failure. We've been talking about a chronic, but acute heart failure usually comes on because of an injury or an MI. Now, acute means it comes on, it's probably going to resolve. So in acute heart failure, you're going to be monitoring central venous pressure, cardiac output, pulmonary wedge, all these things. You can go into pulmonary edema. These patients, these are the ones we talked about that probably they would be going into cardiogenic shock. And so we're going to put them on the balloon pump. We're going to treat them in the critical care unit. These patients really just go from being normal, they had the heart attack or the injury, and now they're in acute heart failure. So there's more things we can do for them because it's acute. Hopefully it's going to go away and they won't have chronic heart failure. So pulmonary edema can happen with any patient. It's more common with acute heart failure patients or stage 4 patients. You have so much fluid that's backing up into the lungs that basically now frothy pink tinted sputum is coming out of the mouth. Patient has to sit up. They're very anxious. It's an emergency. patient basically would be drowning in their own fluids if we didn't do something. Patient needs to have IV Lasix immediately to get that extra fluid off. They would need oxygen while this is going on, a yonker to suction out the fluid as it comes out the mouth. This is a really horrific thing that happens to patients. Very scary. You would feel like you're drowning and going to die any minute. So pulmonary edema is going to happen with patients in stage 4 or the acute heart failure patients. It's not going to happen with anybody like a stage 2 patient, class 2. Okay, let's talk a little bit about peripheral arterial disease, PAD. Most common areas of peripheral arterial disease are areas of the neck, abdomen, and extremities. So peripheral arterial disease, for example, you've got blockages now in your carotid arteries, or you've got blockages in your femoral veins in your legs. Abdomen, you've got blockages down past the aorta, so down in your arteries in your kidneys, to your kidneys. PAD is more common in African Americans, so the number one culprit is arteriosclerosis, atherosclerosis. What's causing it? Well, long-term diabetes, hypertension, cigarette use. These things we're going to promote and going to cause a problem. So think of peripheral arterial disease like coronary artery disease. If you've got plaque that is developing in your coronary arteries, you would also have plaque forming in your arteries, in your neck, in your abdomen, and your extremities. Same kind of thing, all brought on by your long-term habits, the things that you can modify. So sedentary, hypertension, diabetes, cigarettes, no exercise, things like that. Genetics can be a component, but there again, we can't modify the genetics.